Welcome. My name is Simona Glasberg. I am the co-chair of the Rare Disease Committee of the European Society of Endocrinology. And I would like to warmly welcome all of you at this joint European Society of Endocrinology, Endo-ERN and European Society of Pediatric Endocrinology webinar, discussing on a very important topic on the holistic approach to the treatment and surveillance of patients with MEN-1 as well as on their families. We have this evening a wonderful faculty, which is composed of leading people in the field, including Professor Gerlof Volk, who is a professor of endocrinology at UMC Utrecht in the Netherlands. He is very well known. He doesn't need any introduction practically. However, shortly, he's the head of section of endocrinology with the main focus on endocrine and neuroendocrine tumor patients, and specifically on diagnosis, treatment, and follow-up of MEN patients. He's the national coordinator of the European Reference Network Rare Endocrine Condition and co-lead of INET's task force for MEN-1. He will discuss on early recognition of MEN-1. We have also Dr. Carla Peterman. She's a senior endocrinologist working together with Professor Volk at Utrecht University Medical Center, also deeply involved in the treatment and care of patients with MEN, and a very active member of the INET's task force for MEN-1. And Carla will interview this evening one of her patients, Peter Nell Blasboom, that will present the patient perspective. We're all welcoming also Professor Anne-Marie Vergin-Stewart. She's from the Department of Pediatric Endocrinology at Wilhelmina Children's Hospital, UMC Utrecht. She will discuss MEN-1 at pediatric age. And last but not least, we have with us Professor Gregory Kaltsas. He is a professor of endocrinology at the Kapodistrian University of Athens and head of INET Center of Excellence and co-lead of the INET's MEN-1 task force. And he will finally discuss the complexity of MEN-1 in adult patients. Now, before starting, please post your questions as well as your email addresses into the chat. We'll do our best to answer to all of you during this webinar. However, if we'll not have the time, so we'll be happy to send you the answers by email. And without any further delay, I would like to now ask Carla to start the webinar and to introduce her patients. Carla, please. Thank you.
Thank you so much, Simona, and thank you for this warm welcome. I am honored to be here this afternoon, this evening, and I'm especially grateful that Mrs. Pieter-Nel Vlasboom joined me today to tell her MEN-1 patient journey. We go way back and we know each other from our work at the MEN patient organization here in the Netherlands, so we are on a first-name basis. So Pieter-Nel, I want to thank you in advance for being here. We're very grateful. And let's start at the beginning. Can you tell us a bit about what your life looked like when you started having symptoms?
Well, it was in the mid-80s. I was a master's student for German languages with a minor in Serbo-Croatian languages. And I had a great social life. I went to the movies, went out. I liked to read very much. And I had two jobs beside my study. One as an assistant to the dean of the other Amsterdam University, and I worked in the library for languages.
So, a happy, normal, pretty busy life for a master's student.
Right.
How did you first notice something was off?
Well, my first complaint was constant headache. And after a while, my appearance started to change. My head blew up, I became very fat, and sometime later I started to sweat excessively, and I also, I bruised very easily.
At that time, did you seek medical attention?
Yes, of course. I went to my student GP, and he thought my headache was caused by high blood pressure, and he was right on that. So he prescribed me antihypertensive drugs, but they didn't work. So I went back to him. He gave me another drug, didn't work. So I went back to him. And then he said, well, I think you're suffering from a stress-related eating disorder. So he sent me to a psychologist and to the Weight Watchers. I didn't recognize myself in his assessment, but I went to the psychologist, although I didn't have a childhood traumas, and I was so stressed out about my master, it was all going well. And I went to the Weight Watchers, both without any results.
And how did that affect your daily life, your busy master study life?
Well, you start to withdraw yourself from the social life. When you're exhausted all the time, having headache all the time, you just adjust to your new life. So finally I just worked, slept, and ate a little bit. Was weight watching. You are blaming yourself for being like that. You think it's your own fault. You think it must be stress-related, it must be psychological, but it isn't. And after some time, I also developed cognitive and psychological problems. I got disorientated in crowds. I couldn't find my way out in the supermarket, and I started hoarding. That was the funny part.
Yeah. And that was a very, very difficult time in your life. It lasted for 3 years, and you were working your first real job after university. And then you were finally diagnosed with an ACTH-producing pituitary tumor, Cushing's disease, at the age of 26. Did someone finally connect the dots?
Well, my student GP was desperate because I came back, and he couldn't help me. So finally, after all this time, he referred me to an internist. So I went to the internist, I walked in there, and the internist said, don't say a word. I know your complaints. I think what you're suffering from. So your complaints are 1, 2, 3. And he listed all my complaints, and then he said, I think I know what you're suffering from, but let me run some tests to prove it. So the same day I was admitted to hospital. He ran his test, and then it was clear I was a Cushing patient. Yeah, and with the diagnosis, he sent me to the academic hospital in Rotterdam for pituitary surgery. What by that time was still in its infancy, and therefore I'm lucky that I was one of the first Dutch Cushing patients who were operated with pituitary surgery, and I didn't have a bilateral adrenalectomy.
Yeah, exactly.
And after the operation, I also received radiation therapy.
Yeah, so you had this whole treatment plan. You were very young at the time, 26 years of age. At that point in time, did anyone ever consider that it was a hereditary disorder? Did you hear the word MEN-1 then?
No. By that time, nobody mentioned that. After my successful pituitary surgery, I had no complaints for a long time. Well, it seemed like a long time. I had no more headache. So I was very fine. But during the follow-ups from my Cushing disease, they discovered that my calcium levels were high. And about a year after my pituitary surgery, I had a parathyroid operation. And after the operation, it was fine. I was fine. And in the that was the end of the 80s. In the early 90s, I got my first child. So for the doctors, that was proof I was cured.
It was over. They thought this was done. We put an end to this chapter.
Yeah.
But then, in the follow-up, it became apparent that you had MEN-1. When did that came to light?
Well, in the mid-90s, I visited local, an internist in a local hospital, and he was having a bright moment and said, well, he had read something about MEN-1, and he said, well, the combination of your diseases could be a case of MEN-1. So he referred me to the academic hospital to the MEN-1 specialist. And there was a scan made of my pancreas for the first time. And there they discovered I had a large tumor on my a pancreatic net tumor. And also my calcium levels rose again. So a genetic testing was done, and it was clear that I was an MEN patient.
Yeah, exactly. And at that point in time, you also did get your pancreatic surgery for the tumor they found.
Yes.
When you learned about the diagnosis MEN-1, what did that mean for you and your family?
Well, being diagnosed with MEN-1 is bringing a lot of uncertainty, because a lot of organs can be affected, and you'll never know which organ will be affected in your body, and you never know what's going to happen to you.
And what did that uncertainty do to you?
Well, at first nothing, because I had this parathyroid and I had this pancreas I was busy with, and I thought, well, let's handle that first things first. And I also had 2 young children by that time. I had a husband with his own business, so I was far more being a mother and a housewife and supporting my husband than thinking about MEN-1. The only thing where I was concerned about is what should I do for my children? When should they be genetically tested? Things like that.
Yeah. And before getting into the question of testing your children, could you share how having MEN-1 impacted your day-to-day life?
Well, at first, you see a lot of doctors and you have a lot of scans and research, but I consider that as work. And another problem is that nearly every therapy or operation leaves you with another problem, like being hoarse after a parathyroid operation for about half a year. I needed speech therapy for that. And of course, the biggest thing is being a diabetic after pancreas surgery. And yeah, it's if you have MEN-1, that doesn't mean you are affected by other diseases. And it also is that if you are having MEN-1, you are dividing your life in periods. You have periods of relative good health, and you have periods of treatment, disease, and weak health and fatigue. And that affects the way the people look at you. They don't understand it, and it certainly affects your relation to work.
Yeah, exactly. And now to get back to your children. You have 2 children. What did it mean for you and your husband that they might have MEN-1?
Well, me having MEN-1 did not meant for us not having a second child. With my first child, we just didn't knew I was an MEN-1 patient. The only thing that was important to me is that they would not have a doctor's delay like I experienced. And we did not want them to be genetically tested before they could understand the outcome of the testing. So that was important for us. So in that time, there was not a real protocol for children to be tested. So I went to a pediatrician, and the first time I came there, well, he nearly accused me of having a Munchausen by proxy, because in his words, I would like to have my son unnecessary blood test. So I went to another hospital, to another pediatrician, and there both my children were regularly tested.
Yeah, exactly.
And when my son was 18 years old, he had his genetic testing. And my youngest, my daughter, had her testing when she was only 15, a bit younger than we expected. But she was convinced that she was an MEN-1 patient, and we want to know for sure to give her that certainty. It was a very anxious time. It was very, very, very stressful. But they both tested negative.
Oh, that must have been a
So
relief.
it was a great relief for me and my husband and for my children. That's great.
Exactly. And research from our own study group here in the Netherlands, the Dutch Men Study Group, has shown that when it comes to worrying about MEN1, you actually worry more about your children than you do about yourself. Do you
Absolutely.
recognize that?
Absolutely. When you become a parent, you automatically acquire additional Achilles heel. It's your weak spot.
Yeah, exactly. Now I just wanted to circle back to the pancreas again, because what happened after you had your pancreatic surgery in the year 2000?
Well, after my pancreatic surgery, I was a diabetic right away, insulin dependent. And that affected my life more than having MEN1 because I didn't notice the symptoms of my pancreatic tumors. And being diabetic, you're losing a lot of your spontaneity.
Yeah.
Because you're always thinking, do I have my insulin? Where can I eat? Where can I cool it? Etc. So that affected me more. And yeah, a few years, about 4 years after my pancreatic operation, they discovered liver metastasis. And at first, surgery was done because thought it would be operable. But
Yeah.
during the operation, it showed that I had too many liver lesions, so it was open and close procedure. But then, luckily, in Rotterdam, there was a new development. It's called PRRT, what in that time was in its experimental stage. And I was one of the first Dutch MEN1 patients who had 4 rounds of PRRT there. And it had a good result. The MEN tumors kept calm for some years. Yeah, unfortunately, I got a brainstem stroke in that time. It took me a year to recover, but my tumors were calm. And some years later, I needed 2 more rounds of PRRT because of the growth of my tumors. And again, a few years later, I had 2 more rounds of PRRT again.
Yeah, exactly. Yes. And then so you had a lot of PRRT treatments, and then unfortunately after a couple of years, again, growth was noticed. So what happened next?
Well, again, there was something new, radioembolization. I had my treatment just a few weeks ago. This time I did have the symptoms after the operation. I was out for about 3 days. But, well, getting back on my feet now.
Yeah, well,
right.
Thank you for sharing that with us and for being here so shortly after finishing the treatment. We're getting to the end of the interview now, and I want to ask, MEN1 is a rare disease. What does it mean for you to have a rare disease?
Having a rare disease has negative and positive sides. The positive sides are that when you get to a specialist, MEN1 specialist, they mostly are very knowledgeable and they're very passionate about your disease. So the other positive effect is that you see your specialist quite often for over many years, so you grow a relationship of mutual trust, and you get more knowledgeable as a patient as well, and it keeps you and that helps you making decisions about your own health. So it's really shared decision making.
Exactly.
So that's a positive side, and negative sides are, of course, the doctor's delay I experienced, and another negative point is that people don't understand you as a patient, because once you're up and when you're down, and even medical professionals sometimes don't understand your needs. I experienced that once after my second parathyroid operation. I was in a non-specialized ward due to a shortage of beds. And I stayed there because I needed IV calcium and I needed food because I was a diabetic. And they didn't gave me food nor my IV calcium, although I repeatedly told them that I was not feeling well. But they said, well, your blood pressure is all right. I thought, yes, my blood pressure is all right because I have all this medication. And not getting the care I needed resulted in severe laryngeal spasm due to a high hypoglycemia.
The low calcium,
Calcemia.
Yeah, so it's really important to be taken serious in that account. Well, Peter Nel, thank you so much for sharing your story with us today. For closing, would you please tell us how you look towards the future and if there's any advice that you would leave the audience with?
Well, I'm always been and still are optimistic about the future and about the new medical developments. I was lucky to have the best of that. And as an advice to the audience, I would like to say, please listen carefully to even the silliest complaints of your patients. They might have rare disease. Thank you.
Thank you so much, Peter Nel. Simona, we give the word back to you.
Thank you so much, Carla, and thank you, Peter Nel, for your amazing story and for sharing it to us. It is so important for us to hear the voice of the patient and to be able to improve what we are doing on our daily practice, to hear the voice of the patient. I think that this is the main message for myself, at least from your story. And now moving shortly to Gerlof. Gerlof will discuss early recognition of MEN-1. Again, if you have questions for Peter Nel, please keep them or post them on the chat or keep them for the end for the discussion. So please, Gerlof.
Simona, also for the kind words in the beginning of this meeting, and to thank you, Peter Nel, for this really impressive interview that you gave. I think it's so important for all of us to realize how it is on the other side of the table. So thank you again for that. The next couple of minutes we're going to talk about timely recognition of MEN-1, but first of all I'd like to recapitulate what MEN-1 is. MEN-1 predisposes to three main manifestations. First of all, the parathyroid adenomas in more than 95% of the patients, leading to hypercalcemia. Peter Nel also told you about that. The duodeno-pancreatic neuroendocrine tumors and also the pituitary adenomas. These are the main manifestations of MEN-1. There are also other endocrine manifestations, such as lung neuroendocrine tumors and thymic neuroendocrine tumors, especially in male patients. Also, gastric neuroendocrine tumors occur, especially in patients with a high gastrin because of a gastrinoma. Another endocrine manifestation of MEN-1 are the adrenal tumors, and that are mainly adrenal cortical adenomas, which are often, or almost often, benign. There are also non-endocrine manifestations. First of all, breast cancer in female patients. Females with MEN-1 have a 2 to 3 times higher chance of getting breast cancer at a 10 to 15 year earlier age when compared to the general population. Another non-endocrine manifestations are subcutaneous and cutaneous tumors, such as angiofibromas and lipomas. And finally, leiomyomas thus occur far more often in MEN-1 patients compared to the general population. Who should undergo MEN-1 mutation analysis? The guidelines state that first-degree relatives of carriers of an MEN-1 mutation should undergo MEN-1 mutation analysis because they have a 50% chance of having a MEN-1 mutation. But why is it important? Early recognition of MEN-1 is supposed to prevent morbidity and mortality for the patient, but also for the affected family members. And also, early diagnosis alters management decisions for specific endocrine tumors. For example, in case of primary hyperparathyroidism, the surgical strategy in an MEN-1 patient is completely different from the surgical strategy in a patient with primary hyperparathyroidism without MEN-1. In the Dutch data, we looked at the time lag between the identification of an MEN-1 mutation in an index cases up to the time the family members were diagnosed. And what we learned from the data was that before it was possible to do the genetic test in the Netherlands, which was started in 1998, it was found out in 1997, and we started in the Netherlands in 1998, the lag time between the moment of diagnosis in the index patients up until the moment of the diagnosis in the family members was 8 years. After the start of genetic testing, it was reduced to 2.6 years, so that was good. In 2001, the first clinical practice guidelines was published with lead author Professor Maria Luisa Brandi from Italy. After the publication of the clinical practice guidelines, the lag time was again reduced from 2.6 to 1.4 years. So again, that was good. In 2007 in the Netherlands, the university medical centers started to collaborate within the Dutch MEN-1 study group. In this study group, we reinforced the use of the clinical practice guidelines. And again, the lag time was reduced to 0.75 years. So this sounds good. But is it beneficial for the patients? That's always the question. For this reason, we looked at the patients who died because of metastasized neuroendocrine tumors caused by their MEN-1 mutation. And what you can see on this slide is that the patients who died relatively young, approximately 40, 50 years of age, and you see that they could have been diagnosed between 2 and even more than 20 years before they died because of this disease. That means that if the diagnosis was made earlier, the outcome of their disease could have been better. So we think that it is good and that we should strive for making the lag time less large than it is at the moment. When we go back to the guidelines, who should undergo MEN-1 mutation more? First of all, the index cases. Index cases are patients meeting the clinical criteria for MEN-1, which are having 2 out of the 3 classical manifestations being primary hyperparathyroidism, pancreatic neuroendocrine tumors, and pituitary adenomas. Also, patients suspicious for MEN-1 or having atypical MEN-1 should undergo mutation analysis. In this group of patients, patients with multiple parathyroid adenomas before the age of 40 are represented. Also, patients with recurrent hyperparathyroidism and patients with a gastrinoma at all age. Also, patients with multiple pancreatic neuroendocrine tumors and patients who develop 2 non-classical MEN-1 associated tumors. What is important? Why is it important to recognize the patients? But it is more important that you know which general characteristics should raise the suspicion for MEN-1, which was perfectly exemplified by the example of Peter Nell in the interview. A combination of tumors, a young age of first tumors, multifocality of tumors, a positive family history, all should raise suspicion for MEN-1. Also, the occurring of rare specific tumors such as gastrinomas or a thymic net should also raise suspicion for MEN-1. I take you to the outpatient clinic, where we together see a female patient of 35 years of age. She suffers from a non-functioning neuroendocrine tumor of 12 millimeters in the pancreatic tail. We order a fine needle aspiration biopsy, and this shows a WHO grade 1 neuroendocrine tumor. She tells you there are no specific diseases in the family. But after specific questioning, because you already think of MEN-1, she tells you that she has a brother with kidney stones, and he was also told to have hypercalcemia already at the age of 25. This brings us to the question, is MEN-1 mutation analysis indicated? For this, we go to a clinical prediction model which was designed based on the data gathered in the Netherlands and validated in independent data of the Karolinska Institute in Stockholm in Sweden. When we fill in the characteristics of our patient in this prediction model, she scores, because she is 35 years of age, 47 points. She gets another 57 points because she has a pancreatic neuroendocrine tumor. And again, she scores 30 points because of her positive family history, because her brother suffers from probably primary hyperparathyroidism. This totals up to 137 points, giving this patient a chance of 20% for having a positive MEN-1 mutation test. So based on this outcome, I think that this patient should be advised to visit the clinical geneticist to ask for MEN-1 mutation analysis, at least counseling. The next question is, who should be screened for MEN-1 related manifestations? The guidelines state patients who are MEN-1 mutation positive. That sounds logical. Also patients with a familial MEN-1, which means that there is a first-line family member suffering from MEN-1 who is genetically confirmed, and the patient has one associated MEN-1 tumor. But also patients with a so-called clinical MEN-1 should be screened for MEN-1 related manifestations according to the guidelines. But the guidelines already state MEN-1 based on clinical criteria only may be confounded by the occurrence of phenocopies. This was the reason that we decided to study this phenomenon in the Dutch data. What we found was that patients who were mutation negative got their first manifestation 10 to 15 years later when compared to patients with an MEN-1 mutation. The same holds true for the second manifestation with the patients who doesn't have a mutation having the second manifestation 10 to 15 years later when compared to the MEN-1 patients. But more strikingly, as you can see on the left side of this slide, is that patients who were mutation negative in this group didn't ever get the third main manifestation when compared to the patients with MEN-1. And they even hardly ever get a third other manifestation when compared to, especially when compared to the MEN-1 patients. These are interesting data. And even more interesting is that the same study was done in the MD Anderson Cancer Center with completely independent data. And what you can see on this slide is that the outcomes in MD Anderson, in this completely independent group, are completely the same. So again, the patients who are mutation negative have a completely different course of disease when compared to the patients who are mutation positive. And even more striking, when we look at the survival of MEN-1 patients, you can see on the left side of this slide that the life expectancy of MEN-1 patients is more than 10 years shorter when they are compared with patients who were mutation negative. And again, these data were exactly replicated in the data of MD Anderson. I think that this means that we should rethink about if patients who are mutation negative should undergo the lifelong screening in the same manner as the patients who are mutation positive. I think I will give back the word to you, Simona, because thank you for your attention.
Thank you so much, Gerlof. So in the meanwhile, we don't have right now any questions in the chat, so please pose your questions. I would like to ask you about the patients from your experience, the patients that are genetically negative, but clinically positive for MEN-1. What about the screening of their families? Because many times my patients, for example, are asking, what about my children? What should I do? Yeah. So what do you recommend for these patient families?
Yeah, this is a really important question. I think for the patients themselves, when somebody is mutation negative, while having 2 out of the 3 manifestations, you should discuss if they should undergo the follow-up as if they were having an MEN-1 mutation. especially patients with a combination of pituitary adenoma and hyperparathyroidism, appear to have a completely different course compared to patients with MEN-1. With an MEN-1 mutation. For the family of the patients, the question is even more difficult, because the course of the disease in the parents or in the family members is different. And I think, and when I am asked the question, I think how large do I think is the chance they have MEN-1 when they have a neuroendocrine tumor of the pancreas at the age of 20 in combination with hyperparathyroidism? I think this might perhaps we find a mutation later on, and then we can discuss if the family should be screened. But when somebody at 45 has a pituitary adenoma and 55 has a hyperparathyroidism, I think that I decide not to screen for more manifestations, because I think it's a co-occurrence of two different manifestations in a sporadic fashion.
Thank you. So clinical judgment practically decides.
That is, yeah.
Thank you. Another thing that I'm frequently asked in my clinic, for example, is about breast cancer in patients with MEN-1. So from your experience, how would you recommend to screen these patients, both female and men, with MEN-1? How frequently, and for breast cancer?
Yeah, that's again a very important question. First of all, the breast cancer as manifestation of MEN-1 is still debated. I think based on the data, you can say that breast cancer is a part of MEN-1, but there is still debate about that. So that's important to realize. But in the Netherlands, we have decided that we screen females from the age of 40 instead of 50, because that's the current practice in the Netherlands for the general population. We start with MEN-1 patients at the age of 40, and only the female patients, to screen them for breast cancer every 2 years. So not very intensive, but it's an extra screening, extra radiological radiation exposure. So it's always difficult to decide what to do, but that's what we do in the Netherlands.
Thank you. So we have now 2 questions from the audience. Briefly, Rana is asking, who are the patients we should suspect for earliest screening? I think that you've addressed shortly this in the first response, yeah. But can say it again? Who are the patients for earliest screening?
Yeah, and I think that they want to know when they're mutation negative. When they're mutation negative, especially the youngest patients, with, at a young age, the pancreatic neuroendocrine tumor in combination, for example, with a pituitary tumor. So, and especially when the family history is positive, that's a very important predictor for having MEN-1. So these are the patients, and also the patients who have recurrence of hyperparathyroidism. That is also a group of patients which is very important to follow as if they have MEN-1, or even think about that. Yeah.
The next question coming from my colleague from Israel, Maya Shalom. She's asking, in a case of a 62-year-old woman with suspected 2 adenomas in her parathyroid, she has hyperparathyroidism with no indication for surgery in the last 10 years. And in addition, she had an adrenal adenoma. Would you test for MEN-1?
Yes, I would. Yes, I would, because of 2 reasons. The combination of hyperparathyroidism in combination with a non-major manifestation, that's already a reason to test, but then the pre-test probability is low that she has MEN-1. But especially because there are 2 parathyroid adenomas, I think there is really an indication for genetic testing for MEN-1. Yeah, so there are 2 reasons in this patient.
Thank you. The next question from Lynn. If it's mutation negative, it is true MEN-1. What do you think?
But can you, I don't know what the question is.
If it is mutation negative,
yeah,
the true MEN-1.
Oh yeah, oh that's a very important question, and that was the point of the slides which I showed. that if it is mutation negative and there is a combination of two tumors not at a very young age, I don't think that's true MEN-1. So I think that we should rewrite that part of the guidelines and to be more focused in giving patients the opportunity for getting the screening for MEN-1. Yeah.
Thank you. We have now a comment from a patient from Cyprus.
Oh, that's interesting.
And Christiana, please send us in the chat your email and we'll come back to you about the best center in Europe for MEN-1. Thank you. Now moving to, I believe, the last question for you, Gerlo, because shortness of time, from Tia. In cases of pituitary adenoma with only one parathyroid involved, would you screen for MEN-1?
I would screen for MEN-1, but when the patient is mutation negative, dependent of the age of the first occurrence of a manifestation, but I would be hesitant to do the screening as if MEN-1 when the patient is mutation negative in this case.
Okay. Thank you so much.
Thank you so much, Simona.
And we're moving now to the next presentation. If you have more questions, please post them and we'll try to answer them on. So the next presentation is of Anne-Marie on MEN-1 at the pediatric age. Please, Anne-Marie, the floor is yours.
Good evening, everybody. Mrs. Vlasblom, thank you very much for your insight in your own history, as well as the information you gave us and shared with us about your children, because I would like to talk tonight about MEN-1 in pediatric patients, which is a topic which is important for both children affected, adults with MEN-1, as well, of course, as their partners and their siblings. And I would like to talk tonight about when to test and also what to screen for in the pediatric population and what to do if the results of the screening are abnormal. So the first question is when to actually test children, when to do the DNA testing. And I do know that practice in Europe varies slightly. And I think these days most children are tested somewhere between birth and a preschool age. However, it is possible to make different decisions. It is possible to do DNA testing in umbilical cord blood. It's also possible to do this testing, but then actually to keep the results closed and only open them up later. I'm also aware that quite a few parents do decide not to actually have their children tested, but to offer them a screening protocol. So that really is shared decision making, which involves geneticists, usually a pediatrician, as well as very often a psychologist, which I usually refer to as a coach, because I say that's somebody who shares the decision-making process with us. And then you could ask the question, why would you offer DNA testing at such a young age? And that brings us to the topic of at what age can MEN-1 actually already manifest itself in pediatric patients. The last 10 years, a few larger reports have come out which learn us more about the age onset of symptoms in MEN-1. And the slide you can see here is actually from the French group, which report symptoms in children already at the age of 3 years. That was a patient who had an adrenal carcinoma. Also, hyperparathyroidism has been reported in a 4-year-old. However, that child did not need therapy at that age. And insulinomas have also been reported at a very young age. However, it is important to notice that most of those very young patients actually do present with symptoms. So the possibility of very young manifestations is actually the reason to offer DNA testing at a young age, so parents can consider whether they want that. And now, if you either have a positive DNA test result or you decide not to test but to screen, then what to screen for, when, how, when to start. So I would like to use this figure to point out what we do in the Netherlands, and I am aware that there's variations to this schedule throughout Europe and the world. So we offer early DNA testing, and then usually at about the age of 5, or sometimes early if that's the request of the patients and the parents, we do an intake. And at that intake we actually inform parents about symptoms which might occur, especially symptoms of hyperinsulinism are important to point out. So we do an intake, usually we meet the children and then start a yearly follow-up. And then from about 8, we do start laboratory screening, and that also helps in letting the children go a bit more familiar with the hospital setting. And then about from the age of 12, we start imaging. Obviously, if symptoms occur earlier, we would adjust that schedule, but this is the basic in otherwise asymptomatic children. So then they grow into secondary school, and during the adolescent age, we usually wave them goodbye in our transition outpatient clinic, and they go to the adult endocrinologist. Now, what's also very important is now, what are the chances of actually having a manifestation of MEN-1 in a child? Usually I would refer to a child as an individual under 18. The various studies I will refer to have used different age groups. So 18 sometimes is 21. I'm aware that some pediatric endocrinologists actually only see patients until they're 16. So usually I would refer to 18 or 21. And this study from the French group actually shows that in a group of about 900 patients, there were 166 patients who actually had manifestations below the age of 21. And if you were to look at those patients who actually had pre-symptomatic screening, you saw that about 70, a little bit over 70% actually were symptomatic before they reached adulthood. And the most frequently encountered manifestation is actually primary hyperparathyroidism reported in this study. But you can see that also pituitary adenoma is quite frequently reported. Now, obviously, those figures hugely depend on what sort of the basic population those data are taken from. Now, I put in this slide to show what is the actual follow-up schedule we currently use in our outpatient clinic. So we start oral history, as I showed you also in the figure with the children, and do physical examination, laboratory test from about 8, and then the imaging. And for me, most important actually is the oral history as well as the physical examination. And the blood test we start running from about 8 only include quite a small panel. We don't draw blood after in a fasting state. We just take them when they come to our outpatient clinic. Now, a more recent study from a cohort which was gathered in mostly Great Britain, the United States, but also includes patients from Austria, actually reports on about 80 patients from 60 families under 18. And in this group also about 70% had already manifestations during childhood age. Also mostly primary hyperparathyroidism, but also neuroendocrine tumors as well as pituitary tumors. it was a bit difficult to gather from this study what is the group those patients are taken from. I do think quite a lot of surgical centers were involved, so it's always difficult to assess exactly what the inclusion has been and how largely the total group of MEN-1 pediatric patients included is. However, 70% is quite a large number. Now this slide actually shows in various reports the incidence of manifestations in the pediatric age, and you can appreciate that numbers vary largely from about 70% to, on the other hand, only about 12% in another study. What is the overall view is that mostly primary hyperparathyroidism is reported as the most frequent occurring manifestation. So something is missing on this slide, but if we are looking at the age to initiate pancreatic NET screening, a few different countries have been listed, and you can see that screening for neuroendocrine tumors does lead to a penetrance of varying from 2 to about 20% in pediatric patients. However, clinical relevance is pretty low, with 0 clinically relevant reported patients in the German study group to up to about 4% in an Australian and a Dutch study group. All those data have led to quite a wide range of screening protocols. Most protocols actually do advise to install quite a bit of screening, and the age at which screening starts varies slightly from about 5 years of age to about 10 years of age drawing bloods. Some schedules even advise to start screening for insulinoma. I dare to query that advice, because I think that actually instructing parents very properly about signs and symptoms of hypoglycemia might really help them to contact you. So maybe screening could be sometimes changed into watchful instructed waiting. Now I would like to take you to a patient which can help us to discuss how to perform pituitary screening and to address the question, do we actually need an MRI? And I'd like to discuss this topic looking at a female, a girl of 13 years of age. And on the right-hand side, you can see a Dutch growth chart where the green zone is the 95% normal range, and the slightly darker zone is that which composes the target height range. So that's the range where you expect a child to grow. And you can appreciate that this girl now usually grows on the lower side of her normal target height range, but then really deviates. And at the age of 13, she was prepubertal, and after a year of follow-up, no further pubertal signs developed. And at biochemistry, at testing, she was shown to have a raised prolactin in a clinical relevant range. Her gonadotrophins were low, her IGF-1 level was also low, and we then performed an MRI which actually showed a microadenoma. So she was diagnosed with a prolactinoma, and she was treated for that reason. So I think that delayed puberty and impaired growth are a very important marker for development of a prolactinoma in MEN-1 patients. Here on the left side I show a normal pituitary MRI. On the right hand side you see a prolactinoma, which you will appreciate is not the prolactinoma from the previous patient, as this one is a bit larger. What I would really like to point out is that if you talk about pediatric patients, don't forget about braces. At least in the Netherlands, a lot of patients get braces installed, and they really mess up your MRI. So if you consider doing an MRI in a pediatric patient, discuss on an early basis with the parents that if you want to do that, they should contact you before braces are being installed, because otherwise you quite often would have to take them out to get a proper view. So if we come back to the question, do we need an MRI in these children? I would argue that if you watch growth and puberty development, you would see clinically relevant abnormalities. So I think that growth, puberty and biochemistry give us very often sufficient clues for relevant disease for which treatment is indicated. And yes, you would miss silent pituitary adenomas, but those were the ones you would probably follow up. So I think that we can step back a little bit from MRI. We might do one, but then don't repeat them too often, but do just close monitoring of those patients. Now, if we do monitoring and if the results come back abnormal, then what do we do? This evening I won't very deeply go into neuroendocrine tumors. However, I would like to address parathyroid abnormalities, as you have seen that those are quite frequent in the pediatric population. And I would like to have a look at this topic from two patients. And the first patient is age 14. It's a boy who presented with hypercalcemia due to hyperparathyroidism. And on the right-hand side in the panel, you can see on the second graph from the top, ionized calcium levels, which are increased. And the second one from the bottom actually shows parathyroid hormone levels. Now, when his calcium was up, his neck ultrasound actually showed an adenoma, which was also confirmed with PET-CT. We don't always do this imaging, but in this case it was done, and it was decided in close communication with the patient to actually decide to resect the parathyroid adenoma. After that, he was stable from a biochemistry perspective only for a short while, because at age 16 he had recurrent hypercalcemia with renewed hyperparathyroidism. However, school exams were coming up, so it was not a good time to talk about major intervention. He did actually want intervention, but not surgery at that time point. However, he did have complaints of fatigue. So after a bit of deliberation, we decided to start treatment with calcium mimetic. So this was Cinacalcet for a shorter period of time, about 9 months. He actually tolerated it very well, but after he passed his school exams, he did feel he wanted more definitive treatment. At that time, imaging again showed an adenoma, and various surgical options were discussed, and he chose to have just the adenoma resected. And after that, normal calcemia was the new state. So this is a child with recurrence of a parathyroid adenoma, such as is frequently reported in MEN-1 patients. Now, if we go and have a look at the second patient, she's only 10. She's only 10 when she developed hypercalcemia. Also increased parathyroid levels. Due to various reasons, we decided, well, let's see what happens. We followed up on her urine, calcium creatinine levels, and those remained normal. And her calcium actually stayed up, but it didn't increase over time. A neck ultrasound showed a possible small adenoma, And we decided, shared decision making, well, let's just see what happens. And after 2 years of watchful waiting, nothing really happened. She's still feeling quite well, is busy with life, doesn't have any signs or symptoms of hypocalcemia. So basically, at this time point, we're just following up on her and repeating those tests every now and then. So if you look further into hyperparathyroidism in children, and the question is actually, when do we need to treat? And up till recently, if we treat them, treatment would be surgery, or can we actually use medication? So the point is, we don't have proper data on what happens with the hypercalcemia if we don't really treat them. And also, if we do treat them with various options of surgery, which we'll come to in the next slide, the question is, how does this actually affect them in the long-term outcome? Does it really matters for perspective of bone mineral density if you treat them with surgery, yes or no? So we just don't really have the data to advise on. Now, if you go for surgery, either subtotal or total parathyroidectomy have been described in children, or resection of a single adenoma. And the reason to be more cautious in children with subtotal or total parathyroidectomy is the risk of hypoparathyroidism. Now, I'm not an adult endocrinologist, so I don't know if adults do take their calcium supplements. I can tell you, however, from my own perspective, that those children, they just don't. They would for quite a while, and then at some stage, they just, if they develop hypoparathyroidism, they just start skipping on their calcium supplements, and at some stage you really run into problems, and it usually takes a long time to actually get them back on track. So I, from my clinical perspective, I'm quite wary for hypoparathyroidism. However, if you look at the surgical data which are out, for subtotal and total parathyroidectomy, the chances of developing hypoparathyroidism in the literature are not very elevated. So most surgical reports say you can do it pretty safely. And on the left hand side of this graph, you can actually see the disease-free survival, which would be a hyperparathyroidism-free course of life if you do either subtotal or total versus only resecting the adenoma. And you can see that the chances of recurrent disease, which you can imagine after just resection one adenoma, are far larger. So if you look at that left side graph, there really is a point in taking them out all at once. So it's a very difficult topic. And then if you go and look at Cinacalcet treatment in children, there's very little data apart from the nephrology group. And in children, there's one study also from France where treatment has been reported with Cinacalcet in either children with a calcium sensing receptor problem or MEN-1. And in the graphs, the red line is the line for the patients who had MEN-1 and not calcium sensing receptor problems. And you can see that medical treatment actually does really lower calcium levels in those patients. So Cinacalcet actually does appear to be another option in treatment. So hyperparathyroidism in children. Do we need surgery? Some articles state that we should do it if the calcium is more severely increased. Obviously, and I would agree on that, if there's nephrolithiasis or nephrocalcinosis. Reduced bone mineral density in a child, well, that's a really tough one. first we go by Z-scores and not by T-scores, and then a Z-score also has to be adjusted for length, because a Z-score supposes that the length of that child is average, and average does exist, but it's not the most frequently encountered situation, so be careful. However, obviously those data are needed for the long term to know what's wise. So you could go for surgery, but I would say don't do it too early. What kind of surgery? That really is shared decision making. And if you do decide to go for watchful waiting, I would suggest follow up on hypercalcemia with biochemistry as well as urine testing, doing renal ultrasound to check for nephrocalcinosis, and assessment of bone mineral density, but not too frequent. And with that statement on hyperparathyroidism, I would like to conclude with a suggested screening protocol, which does say you should start screening with informing the parents, but being more reluctant in drawing blood and doing very regular imaging. However, those protocols really depend on what are the options for the patient to come in to report with complaints and what is the situation in various countries. So I could really understand that this is something which you would have to adjust for your regional practice. And with that, I would like to conclude and just put in this graph to show you that actually we have a collaboration with the UMC Utrecht, the Wilhelmina Children Pediatric Hospital, as well as the Prinses Maxima Centrum, which in the Netherlands is the Dutch National Pediatric Oncology Hospital. We see the MEN-1 patients in the pediatric hospital and not the pediatric oncology hospital, because we really would like to try and prevent development of oncology requiring manifestations of MEN-1. And with that, I would like to thank you for your attention.
Thank you so much, Anne-Marie, for this wonderful presentation, inspiring presentation and discussion. We have in the meantime two questions from the audience. The first one is on the 10-year-old girl that you presented. Eva is asking, could the case with the 10-year-old girl be a familial hypocalciuric hypercalcemia diagnosis?
She had a confirmed diagnosis of MEN-1, and if the question is, did I check for a second genetic disorder, then my question would be, no, I didn't.
Yeah, most probably the probability would be very low. The next question coming from Anna Silvia, does primary hypothyroidism lead to fewer complications in children? Thus, these cases can be monitored for longer periods of time without surgery and without developing complications.
Does primary hypothyroidism or hyperparathyroidism? Hyper. I think that there probably is a point in not jumping on those patients, but actually doing watchful waiting. It's actually tough though, because as a medical specialist, you try to treat symptoms, and if you screen, I think this is one of the risks actually from screening, because we screen, we see those abnormal digits. And so it's pretty tough not to act on those digits. But if those patients have primary hyperparathyroidism, their calcium levels don't increase too much, and they don't develop severe hypercalciuria and nephrocalcinosis, then we actually possibly might be able to wait. And I think the main question obviously would be, how does that affect in the long term bone mineral density? And those data we just don't have. There's some data on bone mineral density, obviously after hyperparathyroidism, but that's not in the young children and them waiting and not doing anything. And for bone mineral density in the pediatric patients, actually what counts most is puberty. So looking at bone mineral density means you have to include whether that child has entered puberty, yes or no, because that really affects your bone mineral density. So I think we can wait a little bit more, but it took me quite a while to dare doing that. I hope that answers the question.
Yeah, thank you. Let's see if there are more questions. Yes, there is a question from Amir. How to manage mental-related problems associated with hyperparathyroidism? Do they occur in pediatric patients?
I'm not aware of specific psychological problems in the hyperparathyroid patients I have seen. I might have missed them, but I'm not aware of them. What I haven't addressed is the major stress of MEN-1. And from my perspective, the children, I don't think they worry that much about themselves. Their children worry about their parents. On the other hand, I do found that a lot of parents worry a lot about their children, and so we have a close collaboration with the psychology department, and I very often refer parents at first to be able to discuss MEN-1 with their child. So how do you explain it, and how do you go from, well, you know, every child needs a checkup, to you actually have MEN-1 as has your father or your mother, and for that reason we need to do those tests. But specifically related to hyperparathyroidism, I can't answer that.
But related to this psychological problem, just to a little bit discuss more into this question, regarding the transitional process. You know, if you are following a child with MEN-1 for some while, he's getting used to you, you know, and then becoming a young adult, he or she should move to the adult endocrinologist. So how are you doing this transition? If you can share it from your clinical practice.
What actually now helps us is that we see a lot of patients in the UMC Utrecht. So I see them as a pediatric endocrinologist, and either Carla or Gerlof or one of their colleagues would see them in the adult department. So quite often the child is actually already more or less familiar with the doctor of his or her parents. So I always ask them, do you want to go to the same doctor, or would you like to have a different one? Usually they would like to go to the same doctor. And I recall that at one stage, Professor Valk and I thought, well, you know, it might actually be a good idea to install a family outpatient clinic. And we discussed that with a few patients. And I would say, much to our surprise, those families said, you know, we don't want to come parent and child at the same time, because if we as a parent receive unfortunate news about ourselves, we don't want our children to be present. So we would rather come twice than have everything at the same time. And apart from that, I think it's important to educate the children about their disease, and that's pretty tough because your usual adolescent isn't interested in the websites, and always tells you he has forgotten or she's forgotten what you discussed previously. But that's not fair to all patients, because some are quite well aware. So we do find time for preparing the road for transition, and we try to do the first outpatient clinic with the pediatric as well as the adult doctor.
Thank you. Another question from Suet-Ching Chen. Will you use cinacalcet as first line in cases with mild asymptomatic hypercalcemia?
No, I wouldn't. I wouldn't treat asymptomatic hypercalcemia, I think. And I've only used cinacalcet in cases where we did think that therapy was indicated, but for some reason surgery was at that point not the best way to go. I feel that, well, the data we have on cinacalcet are just scarce. However, if the child is symptomatic, I think it would be wise maybe to get some more experience. And I think that there's far more experience, but I'm going to look at my left side in the adult patients with treatment with cinacalcet. So I just think that because there's little studies out there in children, we're more reluctant to do so.
Thank you. We have still a comment from Amir that asked about psychological impact of hyperpara in children. And the comment now is the mental moans do occur in adults, but do we see them in children? So I think that you answered this already.
Thank you for his comment. Thank him for his comment.
It's a idea, you know, for research to look more deep into it. And Su-Ching Chen, regarding the cinacalcet question, is adding that so in asymptomatic parathyroid adenoma, would you perform surgery?
The honest answer is that I've quite a few times involved our multidisciplinary team to discuss those patients, because that's what we always do, and we did perform surgery on quite a few. So I've done that, and then at some stage that's how it works in as a clinician. You come across a few problems, complications, and then you start getting a bit to be more reluctant, and then you start daring to wait. So I think after quite a while of building experience, I now dare to wait a little bit more. And we're thinking about setting up a study to know whether that daring I developed is actually wise or not. I would love to have an answer to the question, but I just don't.
Thank you. If there are no more questions, I think that we will move to the, there is one last question, Anne-Marie, sorry. So Soham is asking, is pore gland exploration routinely done even if adenoma is identified? So I think that this question can be addressed to you, but also to all panel participants.
My answer would be, I'm not totally sure. So I'm not sure whether you are certain about surgical procedures.
Well, the surgical procedures, of course, for children and for adults is what the patient wishes. It is together you take the decision what you're going to do. Sometimes, even in adults, we choose to do unilateral clearance because they really don't want to have a hypoparathyroidism, because there's always a chance for a period of hypoparathyroidism. And when the scans show you that there's only one side that's showing adenomas, then you can also do a unilateral clearance of the neck. But then you know that a recurrent hypoparathyroidism is the case within 2-3 years, and perhaps even within 1 year. And in children, we sometimes, when we decide to operate in the MDT, we preferentially do a unilateral clearance or only removal of only the adenoma, just to give the child some more years with a normal calcemia, but more important, with a good quality of life. because a child has to grow and to function in the society.
And if I understood the question well, the actual question was, is then do we always visualize all 4 parathyroids?
Yeah.
I don't.
Before we go for surgery, then we do the scan, the PET scan, and then we see if on both sides of the neck the adenomas come up. If the adenomas are come up at both sides, then we often remove 3 or 3.5 of the parathyroids.
But not during the surgical
Not
procedure.
during the surgery, no.
Thank you so much to both of you. I have a last question on this, Gernot, please, because I have a patient in my clinic.
Okay.
After subtotal parathyroidectomy and thymectomy with implantation of a half gland into the arm, and after a couple of years, persistent hyperpara with hypercalcemia. Before doing the operation on the arm, would you consider sampling for PTH just to be sure that the origin is in the arm and no other ectopic lung, because it's negative in any imaging?
Yeah, that's possible. That's possible. But what I do in such a case is that I draw blood on both sides. And when you see a difference, when you see a big difference, then you know it's functioning. And then I think that is the that it is the functioning and hyperfunctioning autotransplantation. When you don't see a difference between PTH, I think that it isn't functioning as it could be. Yeah.
Thank you so much to both of you. We are moving now to the last presentation of this webinar by Gregory Calzas on the complexity of MEN-1 in adults. Please, Gregory.
I hope you can see my screen, and it's there, but I don't know why it's not showing.
We see it, Gregory.
Okay, I'm sorry about this. Okay, thank you very much for the invitation, and on behalf of INETS, I would like also to thank you for involving the INETS MEN task force, and thank you very much for the introduction. So Professor Volk has already discussed the whole spectrum of the disease, and he has also mentioned that some of these patients, they suffer from morbidity and mortality, and they have some reduced overall survival. And 2 are the main reasons for involving this effect on survival. One of them is a pancreatic neuroendocrine tumor, and more rare, the thymic and neuroendocrine tumors, thymic carcinoid. So I'm going to take you through a journey of a patient with a pancreatic neuroendocrine tumor to see the evolution of her disease and the decisions that were made. So this is a patient that I presented in 1998, and the age of 16 years old. And she was noted to have elevated calcium levels. And the diagnosis was primary hyperparathyroidism. So during that time, she had 3.5 parathyroid glands removed following the discussion we had. And these were found to be hyperplastic glands. At that time, a pituitary MRI was performed, and it was noted to be normal. In 2003, at the age of 21, she had recurrence of her primary hyperparathyroidism. She had resection of a residual hyperplastic gland, and after that, she had normal calcium levels. She was decided to follow up. In 2010, she had a 3rd recurrence of a primary hyperparathyroidism, and at that time, the diagnosis of MEN-1 was suspected. And there was no family history, however, that was suggestive of MEN-1. So, when she was followed up, she had no symptoms of functional syndrome from any other hormonal secretion, at only elevated calcium levels. She had no clinical stigmata of MEN-1, except of high BMI, and biochemistry was consistent with primary hyperparathyroidism. The pituitary function was normal, along with the normal pituitary imaging, and that's the post-contrast imaging, whereas an MRI of the abdomen revealed that she had an 18mm lesion at the tail of the pancreas, and where there was some lesions, others in the body that not very well clarified, the adrenal glands were normal. She had the somatostatin receptor scintigraphy, which demonstrated a unilateral uptake in the pancreas. And further on, she had an endoscopic ultrasound, which revealed 4 lesions, ranging from 8.8 to 19.4 millimeters in the body and tail. And there was a query on lesion of the left hepatic lobe. At that time, an FNA was performed and revealed that this was indeed a pancreatic neuroendocrine neoplasm with a Ki-67 labeling of 1%, whereas the CT scan of the chest was normal. And this is her imaging, and this is an MRI. This is a T1 weighted image, and this is a T2 weighted image. And as you can see here in the tail of the pancreas, there's this obvious pancreatic lesion. So what about these lesions in the pancreatic lesions in neuroendocrine tumors? It has already been mentioned by Professor Wolf, but as we know, they can present at a much earlier age. They are multiple. Majority are non-functioning, about 50 to 70%, and they can be functioning enough. Most common is the ones that they secrete insulin, insulinomas. When they secrete gastrin, usually this is from the duodenal neuroendocrine tumors, more rare vipomas and glucagonomas. And as you can see here is the first initial studies that they saw the distribution of these lesions. And as you can see is the age of presentation, where by the age of 20, they have a 9% as a chance of having a pancreatic neuroendocrine tumor, and these are non-functioning 3%. And by the age of 50, this goes up to 53%, and by the age of 80, up to 84%, the majority are non-functioning. And in addition, in this CT scan, you can see that they can be multifocal by seeing these two enhanced lesions in the administration of the contrast, usually the tail of the pancreas. So it's very important to know what is the risk of these patients in developing more extensive disease. And because we do know that about 18% of the patients, they can have either localized zone distant metastasis, where if you don't treat these patients at the age of 70, this percentage can go up to almost 50%. So this is the first study that was published from the registry from France, which provides us with some information about the chance of these tumors having some metastasis. And you can see that the ones that are between 0 and 10 millimeters, the chance of developing either metachronous metastasis is relatively small, about 4%. When the size is between 11 and 20 millimeters, this is a greater chance of about 10%, but if it exceeds this level, then the chance increases substantially. And this has been taken into consideration in the guidelines that they were developed later on. So, this case, in this case of a patient, it was decided to have a partial pancreatic resection and the body and the tail, and the spleen was resected, and some lymph nodes were resected as well. And histology revealed that this was a 3 grade 1 neuroendocrine tumors, size of 4 millimeters, 15 millimeters, and the largest one that I showed you, 19 millimeters. There were also multiple microadenomas throughout the specimen. The lymph nodes were negative, whereas the suspicious lesion in the liver was found to be focal nodular hepatic hyperplasia. And at that time, MEN genetic analysis was negative, and this is food for thought because we have a patient that she had manifestations of MEN-1, clinical manifestations, she had no family history, and she had a negative MEN-1 mutation analysis. So in February 2014, she had a further MRI of the abdomen, which revealed that there are some gallbladder stones and borderline lymph nodes that have been stable in size. And the primary hyperparathyroidism was persistent, and the calcium levels were between 10.8 and 11 milligrams per DL, where an MRI of the abdomen revealed that there was now an 8.5 millimeters hypervascular lesion in the head of the pancreas. And for the first time, an MRI of the pituitary, that's a post-contrast MRI, revealed a macroadenoma, 6.5 millimeters in the right part of her pituitary. So as she was noted to have these lesions, she had another endoscopic ultrasound, which revealed hypoechoic lesions in the head of the pancreas, measuring almost 10 millimeters and 4 millimeters. And an FNA was again performed, the largest one, revealing a Ki-67 of 1%. Scan of the chest was normal. So at that time, the patient expressed the desire to become pregnant. And we do know that the homeostasis of calcium changes during pregnancy because we have decreased demands of calcium in order to sustain the development of the fetus. So at that time, her calcium levels were about 11 milligrams per DL. Her bone mineral density was normal. Her 24 calcium levels in the urine and renal ultrasound revealed no abnormality, where at that time repeated genetic screening showed that there was no pathognomonic mutation related to MEN-1. So she underwent a healthy female, and he underwent a healthy pregnancy, and a healthy female was delivered in 38 weeks of gestation. So I would just want to clarify a few things about problems with hyperparathyroidism in pregnancy, because this is a relatively rare and occurs in about 0.05% of all cases of hyperparathyroidism, and the majority of the cases, about 10% of the cases, they're genetic causes. But these calcium levels enable some risks for the mother and the fetus, and the risk for the mother is that besides hyperemesis gravitarum, she may develop nephrolithiasis, cases of pancreatitis, preeclampsia, and hypercalcemic crisis, whereas the risks for the fetus involve hypercalcemic crisis, intrauterine growth retardation, and miscarriage. Therefore, the suggestion for close monitoring of serum calcium in order to optimize maternal and fetal outcomes. Although there are no prospective studies available, there are recently some guidelines that have been published. And in these guidelines, they suggest that cases of mild hyperparathyroidism, as in our case, the patient with calcium levels below 11.4 milligrams per day or 2.85 millimos per liter, conservative treatment is suggested. But in cases that will have higher levels of calcium, then we do that with adequate hydration and cessation of any medication that could affect calcium levels, like thiazide diuretics and calcium supplements. And there are some cases that cinacalcet has been administered as it crosses the placenta, and it hasn't been associated with any gross side effects, but as you can see, the numbers are relatively small. And of course, we should avoid giving bisphosphonates and denosumab because they cross the placebo. There are some suggestions of oral phosphate, but the safety and efficacy has not been documented. And of course, surgery is the option that may be required, particularly in cases of severe hyperparathyroidism and high calcium levels. Coming back now to our patient, she was followed up after her delivery. An MRI of the abdomen was performed in November 2015, which revealed now that the lesion has grown up to 13 millimeters, and there was another lesion of 6.8 millimeters. And somatostatin receptor scintigraphy revealed a moderate uptake, and the tumor markers were all normal. And the pituitary microadenoma was stable in size, as you can see here, and the calcium levels remain less than 11 milligrams per DL. A further MRI was performed in 2016, which revealed a further growth of the lesion, of the previous lesion, of the largest lesion, and further MRI, because we were very worried about this substantial growth of the lesion, revealed that there was again subsequent increase in the size of the lesion, now reaching almost 20 millimeters, whereas the remaining lesions were stable. And the patient at that time, having had a partial pancreatectomy and having been discussed all the cases of further pancreatectomy, which was going to be a total pancreatectomy, decided to be treated with somatostatin analogs. However, and subsequent MRI revealed that there's further growth of the lesion, which is now almost 22 millimeters, and there was a growth of the other lesion as well. At that time, a CT scan of the chest revealed no abnormality. And what about the neuroendocrine tumors in the bronchus and in the thymus? This can be detected radiologically in about 23-29% of the patients, the median age of 45 years. And they're usually not very aggressive. They have a low growth rate, and they have an indolent course, and they rarely develop metastasis. They can be either typical or atypical carcinoids. The majority of them are typical carcinoids, but we have to be careful of the thymic carcinoids. And here is a typical carcinoid in a patient with an MEN-1. However, the thymic carcinoids, which are not that common and they have a more male predominance, they're rarely functioning, but they do follow a more aggressive course. And about 53.5% they develop metastasis, and 20% they are associated with the adverse outcome in patients with MEN-1. Previous studies have shown a hazard ratio of affecting overall survival about 4. And here is a patient with thymic carcinoid, but in our patients, the CT scan was normal. So there is some controversy about how often we should screen these patients. And there are implications that the protocols may evolve, but this is an issue that we can discuss later on. So what about pituitary adenomas that were found in our patients? There are some recent data and some data for the French series of a large number of patients, 500 patients, and about 36.7 of them, they had pituitary adenoma. The majority of them were microadenomas, and you can see here the hard disk calcification that reside within the pituitary. And the macroadenomas, they are usually good grade because they were not involved in the cavernous sinus, and only minority was invading the cavernous sinus of higher grade. And as already mentioned, majority are macroadenomas and they secrete prolactin, but the incidence of the non-functioning pituitary adenomas is increasing. And in that series, there was the follow-up, and it was about 3 years, and in 136 patients that they had either larger tumors, only 4 patients, or only 4 developed some progression, which is a low incidence of 2.9%. In the Dutch series, they look at the non-functioning pituitary adenomas, which the majority are macroadenomas. The data are more reassuring because after a follow-up period of 5.3 years, only a small percentage, less than 10%, developed a minimal tumor growth. So coming back to the patient I described to you, and I can see you some images for what I shown that there is a growing lesion in the head of the pancreas. This is the remaining pancreatic head of the patient. And as you can see in this MRI in 2015, this is the lesion, and this is the other lesion that was noted in addition to the largest one. And almost a year later, you can see that this is more prominent. And a year later, this has almost doubled in size. And these are the findings from the endoscopic ultrasound and sequentially from 2014, 2016, and 2017. And you can see that in the endoscopic ultrasound, here is the lesion that is growing, and it appears to be the 2 lesions that are colliding, they develop a largest lesion. So we had a patient now that she had been operated. She had a partial pancreatectomy in the past. She had now the tumor that was growing, and we discussed the options with her, and we said if he would carry on monitoring him to do a further FNA to see what was the Ki-67 of the evolving lesion, if she had any further treatment with doubling the dose of somatostatin analog, or any other forms of medical treatment, or if the more advisable option was surgical intervention. And I'm just reminding you what I have shown you previously, that the chances of a patient that has a tumor that more than 2 centimeters of developing either distant or local metastasis is increased, and particularly in a patient that has a high tumor growth rate. So the patient decided to have a removal of her remaining of the pancreas, and she had the Whipple procedure, and the specimen was 2.2 centimeters, the largest diameter. The Ki-67 has increased to 8%, and this is not very common because the majority of the pancreatic neuroendocrine tumors are grade 1, but this was a growing tumor, and fortunately for her, the lymph nodes that they were resected were negative. She had also multiple macroadenomas in the specimen, and there was immunostaining for insulin and VIP, but the levels were not raised and she didn't have any functional syndromes. Therefore, she was on insulin requirements and pancreatic enzymes. And of course, the role of a multidisciplinary team is very important to deal with these patients. And in centers that they have a big volume of MEN patients, all these modalities are required to treat the patients, and the patients that they develop metastasis, and other specialties, particularly oncologists, are also involved. And just to remind you, and as I'm closing up this session, what Dr. Valk has initially shown. This is from the guidelines that they were published in 2012. And you can see here the major organs that are involved, and they make the diagnosis of MEN-1. Primary hyperparathyroidism, usually hyperplasia, but they can be adenomas as well. Enteropancreatic neuroendocrine tumors, anterior pituitary tumors, Pancreatic neoplasms, usually adenomas, and are mostly benign, and neuroendocrine tumors that originate for the former foregut and involve the bronchial and thymic neuroendocrine tumors. And in cases of gastrinomas, we have type 2 or acielomas. And of course, we shouldn't forget the non-endocrine manifestations, and they can help us sometimes make the clinical diagnosis, because these patients can have in a high percentage facial angiofibromas, collagenomas, lipomas, and as you can see in this image, this is a patient with an angiofibroma. They can be multiple, and a patient with a collagenoma and a lipoma, which can substantially increase in size and cause discomfort. And this is the way we make the diagnosis, as a summary of what Professor Volk has made, and that the diagnosis is made either clinically, if we have the two patients that are involved, and familiar, if we have a patient with an MEN-associated tumor in first-degree relative, and genetic, if there has a known mutation. And thank you very much for your attention.
Thank you very much, Gregory, for sharing with us from your experience and this wonderful presentation. I would like to ask all the faculty to join us for the final discussion. And there is a first question from Pia Burman. I have a patient with MEN-1 who plans to get pregnant, and she wants to know if it's possible to do a prenatal screening of her fetus for MEN-1. Have you any experience on this?
Yes, I have.
So whom is that? Fine.
Please go.
In the Netherlands, it is possible to screen before getting pregnant. One patient actually has done it, and she has now a healthy son. And because it was such a long trajectory, they decided not to have more children. But it is in the Netherlands, it is possible, and it has been done once or twice. But perhaps Annemarie, you have more experience in that.
I would say concerning pregnancies, you would have to differentiate between pre-implantation therapy, it is called, or pre-implantation genetic diagnostics, which is an option. And also, I think after a pregnancy has come to be, also diagnostics whether the fetus is affected, yes or no, is possible. I'm not aware of that test very often in the Netherlands actually leading to conclusions about pregnancy terminations, but technically speaking, that also, I suppose, would be an option which would be discussed if parents would want that. But so pre-implantation genetic therapy, yes, that is available, and that is being done.
Yeah, it has been done once or twice in the Netherlands now.
Yeah.
Thank you,
Yeah,
Greg.
this is my experience as well, because we have some patients that they would like to know, what is going to be the outcome of the fetus, if it's going to develop, and according to the preference of the patients, and you can have this information if they decide that they would use it at an early pregnancy stage.
We have another question here on pregnancy. There are described cases of parathyroid gland ablation in primary hyperparathyroidism during pregnancy, and this might be a good option for MEN-1 patients in hypercalcemic crisis during pregnancy. Do you have experience with ablation?
I don't have experience with that intervention in pregnancy and not in MEN-1. And ablative therapy might hamper the surgery afterwards, because there could be, I think that surgery is in the end always necessary in case of primary hyperparathyroidism, but I'm not sure about that. But I don't have experience with that. But perhaps you, Gregory?
I know that it has been described in some case reports in the literature, but the majority of the patients with primary hyperparathyroidism, they don't have that high calcium levels that they're going to develop a hypercalcemic crisis, and that they could affect the development of the fetus. And as I showed you in my case, and you have much more patients than I have, and probably more experience, the patients can usually, perform well during their pregnancy. And I had another patient that she had a small period that has received a sinacalcet, and then the pregnancy went okay. And another patient that decided to undergo further surgery, because she didn't want to take any chances for the fetus. That's my limited experience.
Yeah, I have exactly the same experience. That in general, a mild form of hyperparathyroidism isn't a real problem in the pregnancy. I always advise my patients before getting pregnant to check the calcium level to see if an operation before pregnancy is indicated. But when somebody is pregnant and there is a mild hypercalcemia, I haven't seen any problems with that in the last years.
Thank you. I would like to ask your experience regarding, in general, pregnancy in the presence of neuroendocrine tumors in the pancreas, in the lung or thymus. Sometimes patients are asking if the pregnancy could negatively influence the growth of these tumors. So what is your experience regarding the growing of the tumors during pregnancy, or if it's any risk at all?
Well, when women want to be pregnant, I always check if the tumors are stable. And in case of stable small tumors in adrenal or in the pancreas or in the lung, because in females I've seen only once a thymic neuroendocrine tumor, so that's not a problem. And in case of thymic neuroendocrine tumors are often very aggressive. But they occur in male patients. But when the tumors are stable, I didn't see any problem up to now with growing of tumors during pregnancy. So the influence isn't very big, and that's also the reason not to go for a Whipple procedure or for a pancreatic tail procedure, just to prevent problems with the glucose during the pregnancy. So when it is stable, I say to my patients, it's safe to get pregnant.
Thank you.
I need to add that, there are not a lot of data in the literature regarding this issue. And if you have data on that, Gerlof, that's a good opportunity that you can publish. Because there is a positive data in the literature.
Yeah, again, you're so right. Perhaps we should do it in our task force. I think that's a good retrospective studies question. Yeah, very good.
Now we have a couple of questions from our audience. First from Maria. For patients with full clinical phenotype of MEN-1 but negative genetic analysis, what else could we do in terms of the genetic confirmation?
Shall I take this one?
Well, will you take the question? Very good.
Yes. Yes, I think first it's very important to ask what kind of MEN-1 genetic testing was performed. Because if large deletion testing was not performed, then you have the full clinical phenotype, which I translate to be with the neuroendocrine tumors and the primary hyperparathyroidism and the pituitary neuroendocrine tumors. I would say check the extent of MEN-1 testing, be sure large deletion testing has been performed, and then look at other genes that could explain the phenotype as well, such as CDKN1B, but there are more CDK genes that currently are known to give an MEN1-like phenotype. So you really should go look with your geneticist, what's the panel that has been performed. If an extensive panel still remains negative, I think you should consider this really a clinical MEN1 and follow up as such, remembering that maybe in the future new genetic findings might occur that can explain this phenomenon.
This was the case. So in our patient that I presented, that the initial genetic testing was negative, but then was repeated and MLPA was performed, the deletion was found. So that's why we have to take into consideration all the possibilities that they're not only point mutations, but they can be deletions as well.
Thank you. Next question is from Soham. Imaging modality of choice for identifying pancreatic neuroendocrine tumor, if you can comment. Frequency of scanning for carrier of genetic mutation is multiple CT. Oh, there are actually 3 questions here in one. Is multiple CT scan over the course of time a concern? So we have 3 questions. Which is the you know, okay.
And for the answer, we go to Carla because she recently published on this topic.
Yes, and I think the backbone of the screening for pancreatic neuroendocrine tumors in MEN-1 is the MRI, as we recently published a paper showing that the MRI has really good positive predictive value and sensitivity, is not lower than a CT scan. And with a CT scan, obviously, you have to worry about ionizing radiation in patients that need lifelong screening. Then you would probably ask, should we do EUS? Because that's also a surveillance method. EUS is operator dependent, it's not available everywhere, and it's also an invasive procedure for patients. You see more small neuroendocrine tumors in the pancreas with an EUS, so the sensitivity is higher. But the question is if those small neuroendocrine tumors are clinically relevant, and we would want to know about them before we see them on MRI. And in our opinion, and from the data that show that the growth of these small neuroendocrine tumors is very indolent, we would not choose to perform EUS as a primary screening method. So we would use MRI. Then the second question was, at what frequency would you use the MRI? In patients without any evidence of pancreatic neuroendocrine tumors, current guidelines state that we should perform that every year. Since the guidelines, there has been more information about the natural cause of these small neuroendocrine tumors, showing very slow growth. So it is safe to perform that like every 2 years, and perhaps with a little bit longer pause. When you have a tumor, it's important to get an idea of how fast it's growing. So we usually perform it after 6 months, and if it's stable, yearly, and perhaps stretch it a little bit longer if continuously stable. But it's very important to monitor the growth and to see what the growth rate is. And the third part of the question, what was that again?
I thought it was about CT, but...
Yeah, it was about the risk of concern regarding multiple CT scan overlap.
Yeah.
Yeah,
Exactly.
yeah.
No,
Well, for the pancreatic neuroendocrine tumors, we screen with MRI preferentially, but for the lung neuroendocrine tumors, it's a different story because MRI isn't the best way to study the lungs. And that's the reason that for the lungs, we do once, for screening purposes, once in the 3 years, a low-dose CT scan without contrast enhancement. So that the ionizing radiation isn't very much, and the frequency is not very high. But the guidelines state to do it every year or every 2 years, and I think that's a bit much, but that's especially to find the thymic nets in male patients. But when you want to diagnose a thymic net, because they are very often very aggressive, if you want to diagnose a thymic net in time, then you have to screen very often with a contrast-enhanced CT. And that's not our practice. And luckily, it is very, it doesn't occur very often that there's a thymic net. But as soon as you see anything concerning the thymus on the screening CT scans, low-dose CT scans, I go on top of it. I'm going to sit on top of it and see if there's a problem with the thymus in patients.
And if I may add here, the tumor growth rate is very important to be considered, as I showed you in the case of this patient, because it was very, very, led us to the intervention that really saved her life. And another question, I haven't seen that very often. You have the vast majority of patients. Have you seen any increasing grading in such a patient that I presented? Because I have never seen that before.
Yeah. Well, during your presentation, Carla and I discussed what we should have done in the patient. And afterwards, it's always very easy to say what is the good answer. But when a tumor is growing more than 2-3 millimeters per year, I already expect that it is a low-grade 2 tumor. So, and when it is progressing faster than that, 5 millimeters, 6 millimeters, well, I always say I say we are going to remove this tumor because I expect that it's a higher grade 2 tumor. So I was not surprised seeing the outcome of the Ki-67 of 8% in that patient. But it's always difficult because sometimes also in growing tumors, it's a grade 1 tumor and you don't know why the tumor grew on MRI.
Can I have a provocative question, for example, in your patient, Gregory, because I assumed you were a little bit, limited in your decision to do another surgery because the patient had already almost subtotal pancreatectomy. So would you consider, or have you any experience with RFA in patients, young patients with persistent, slowly growing pancreatic neuroendocrine tumors?
Thank you, Simona, for this comment. Patient's preference is always should be taken into consideration, when we're deciding the treatment. And initially, we were sure that this is not a benign, tumor that is growing, because as Carlos said, the mean growth rate in these patients is about 1 to 1.2 millimeters per year, if any. And this one was growing much faster than that. But having had, the partial pancreatectomy, she was very hesitant to go on, further, have a total pancreatectomy and become insulin dependent. That's why it was mainly her decision. I don't have any personal experience by doing RF ablation in such patients. And I don't know how, sure you're going to be by doing RF ablation in a patient that is growing so fast without doing an oncological resection. And I would be hesitant to do an RF ablation in such a case.
Yeah, perhaps I can add a comment on that. I completely agree with you, Gregory, because RFA, it's also dependent on the location of the tumor, the growth rate, and also the size of the tumor. And especially when tumors are growing as fast as the patient Gregory showed, I don't think that the local therapy is enough. That tumor should be removed. In fact, what we are doing now, we have study opened now in the Netherlands, in Utrecht, about radiotherapy for tumors smaller than 2 centimeters, which grow not less than 3 millimeters per year. So the slightly growing tumors, and we are going to look if it is feasible, if it is safe, and also if the tumor growth is stopping when we do radiotherapy with an MRI, so the so-called MR-Linac. But I hope that we will get the results at the end of next year, and I hope to present it then.
Thank you. We have some questions from the audience. What about PRT? So I think that we had already our patient this evening sharing her experience with repeated PRT. Can you a little bit discuss on the usefulness of PRT as a treatment option in patients with progressive MEN-1 related pancreatic or other neuroendocrine tumors?
My experience is that they do better because they are slow-growing tumors and they do better. But I have treated patients with neuroendocrine tumors in the context of MEN-1, and they're doing better compared to the patients that have sporadic diseases. But as your patient showed, Carla, your patient relapsed, but she's still alive after so many years.
Yes, she's sitting here, and she's very happy with the PRT for so many years.
Because it diminished the growth of some lesions, and it even may disappear some of the lesions.
Yeah. It's
4 years without complaints.
Yeah. But perhaps
she's mentioning that it really slowed the growth of the tumor, and that some lesions were even disappearing, leaving her with a really stable situation for 4 years.
Yeah. But I agree with Gregory that the PRT and MEN-1 is really beneficial for the patients, perhaps even more beneficial compared to patients without an MEN-1 mutation. For lung nets, it's different because they are not always somatostatin receptor positive. But I think it is really necessary to look in a study if the difference are real or only our expert opinion. So that would be also a very interesting issue to be addressed in a retrospective study.
So we have many plans for our task force.
Yeah, we have.
Okay, the next question from Christina to Dr. Vejin Stuart. How often will young children without a genetic study develop asymptomatic tumors with a delayed diagnosis and worsen their prognosis because of that delay? She thinks that most aggressive tumors will be diagnosed because of symptoms.
I would agree that usually those children will develop symptoms. However, I feel that even if you don't do genetic testing, you can actually do the routine screening. So you can follow up DNA not tested children within the same protocol. So you could also see them yearly and discuss doing bloods and discuss doing scans, yes or no. So, and I would always advise to do that. So I can understand you don't want to do the testing, but then just do the follow-up. And if you don't do testing or follow-up, then I agree that you might make a late diagnosis of delayed puberty and impaired growth. And so it might be harmful to diagnose a prolactinoma that late, or you would not want to diagnose hyperparathyroidism when renal problems have developed. So just do the follow-up according to the protocol. And if you refrain from DNA testing.
Thank you. Another question is, how is your experience with the management of parathyroid carcinoma in MEN-1 patients?
Well, in the Dutch database, we didn't encounter any parathyroid carcinoma within the course of MEN-1. So it might happen, but it is really, really, really seldomly occurring. So I don't have any experience with that.
Yes, Gregory?
I don't have any experience, but the ESMO guidelines will be out soon describing all the management in patients with parathyroid carcinomas, which I don't think is that different from the patients they develop in the context of MEN-1. Yeah. But I think it's important to add that when a patient has a primary hyperparathyroidism, I'm not afraid that it could be a parathyroid carcinoma, because I didn't encounter it myself, and also from the studies, it doesn't come out that parathyroid carcinoma is one of the features of MEN-1. But we have to realize that we screen for hyperparathyroidism, so there are and we operate at a certain moment in time, and we follow the patients up. So in growth or in tumors which get larger than we expect, we are going to operate. Thus perhaps we operate before parathyroid carcinoma is occurring. That might be the case because of the screening practices.
Thank you. So maybe a last question from my side before we're closing. Gregory, you showed that you used somatostatin analog treatment in your patient. What is your experience and also the Utrecht team regarding the effectiveness of somatostatin analogs in this setting?
Thank you for asking this question, which I'm going to address it to Gerlof, because he has already developed some prospective study from this issue, which apparently has not been evolved into clinical practice. But I know that there was a paper, a retrospective study that was published, I think it's from Italy, that showed that they had some effects. But Gerlof has already designed a prospective study, so he can probably tell us more about this.
Yeah, and the reason for designing that prospective study protocol was that there is not enough data. The Italian study is interesting, but not enough evidence for the use for preventive use of somatostatin analog use. The idea is that possibly less tumors occur in tumors and that they grow more slower. But the tumors already grow slow. This that makes it difficult to use somatostatin analogs in patients without metastasized disease. That's the reason that our Utrecht experience is only in patients with metastasis, and that's the same as in patients who have sporadically occurring neuroendocrine tumors, and then the experience is really okay, it's good. They're mostly stable, and I'm not sure that the somatostatin analog is the thing that makes the tumor and the tumor growth stable.
Yeah.
I mean, as you saw in our case, the patient was administered somatostatin analogs, but it didn't have any effect on her tumor growth rate.
Yeah.
Okay, I think that we don't have any other question in the here online. And we are getting to the end of our webinar. It is a time to thank very much indeed to all participants, specifically the wonderful team from Utrecht, Gerlof, Carla, Anne-Marie, as well as to Gregory from Athens for sharing the expertise and taking the time and for discussion. It is amazing to have a patient with us, and thank you so much, Peter Nell, for sharing your story with us, for enlightening us, for giving us a reason to become better doctors and medical carers, and to improve what we are doing in the clinical practice. And thank you to the ESE team for the platform and for the support, and wishing you all the best and have a wonderful evening. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you, Simona. Thank the organizers and thanks the team that hosted us.